Okay, if I could have everyone's attention, please, we can get started this evening. I'd like to welcome everyone to GRCC, Grand Rapids Community College. This is our fourth year hosting Michigan State University College of Human Medicine's Your Health Lecture Series. And I'd like to thank everyone for taking time out of your busy schedules to come out this evening. My name is Paul Krieger, a professor of biology here at GRCC, and I'm a proud alumnus of GRJC and the coordinator of tonight's event. Our sponsors for this free public event are GRCC, MSU's College of Human Medicine, and Spectrum Health. Let's please give them just a nice round of applause, please. In the words of our new college president, Dr. Bill Pink, we strive to remain relevant and responsive at GRCC by offering an accessible and affordable education to a wide variety of students. Whether it's for a transfer student or for a student enrolled in one of our degree programs, GRCC is a great place to start your college education. You're sitting in the science auditorium of the Calkins Science Center at Grand Rapids Community College, and it is home of the Biological Sciences Department as well as the Physical Sciences Department. For more information about our wonderful programs, you can check out our website at grcc.edu. Now I would like to introduce Mark Breavy, Director of Community Engagement and Outreach at MSU's College of Human Medicine, who will introduce our speaker for this evening.
All right, thank you, Paul. And as Paul said, this is the fourth year we've done this talk, and we do a number of these Your Health Lecture Series events around the state. And what I really enjoy about this one in particular is I can walk from my office to get over here, where, you know, when I go to Marquette, it's a 7-hour ride in the car. So I do appreciate that. Certainly, as Paul said, this couldn't be possible without our sponsors. Grand Rapids Community College, Michigan State University College of Human Medicine, and Spectrum Health. And without further ado, I'm going to introduce our speaker, Dr. Cara Poland. She's a board-certified physician specializing in addiction medicine with the Spectrum Health Addiction Rehabilitation Program. She's the medical director for Substance Use and Pregnancy Clinic and also assistant professor at Michigan State University College of Human Medicine. Dr. Poland earned her medical degree from Wayne State University School of Medicine in Detroit, and she completed her internal medicine residency at St. Joseph Mercy Hospital in Ann Arbor and her addiction medicine fellowship at Boston University in Massachusetts. Dr. Poland's clinical interests include safe opioid prescribing, medication-assisted treatment of substance use disorders, and treatment of females with substance use disorders. Please welcome Dr. Poland.
Thank you. So for those of you guys who have seen me lecture, the first bit of slides will look pretty familiar. And then I actually updated all my slides for this, so I'm pretty excited. So I do not have any financial disclosures. I don't think I need to do that, though, because this isn't a CME event. So we'll go on. So here are just some measurable objectives for you. So we're going to talk a little bit about how addiction is a chronic disease, discuss the current epidemiology from a national perspective, and then come right down to Kent County statistics, understand some of the barriers to accessing medication-assisted treatment, and understand how treatment works in a biopsychosocial model of disease care. So I am also, in full disclosure, president of the Michigan Society of Addiction Medicine, which is a chapter of the American Society for Addiction Medicine. And this is our definition of addiction. So if we'll notice, the definition of addiction has a lot of commonalities with other diseases, like, say, diabetes. It's a chronic disease. It involves the brain, like something maybe like Alzheimer's disease. There's different circuitry involved, and there's characteristic signs and symptoms and manifestations that can lead us to an appropriate diagnosis. So it's good to remember that this is, in fact, a disease. The United States is pretty unique in considering substance use, a moral failing. We don't see that in other areas of the world. And so I always like to kind of point that out. So these are some of the characteristic signs and symptoms of addiction. And you'll see I have so cleverly highlighted the A, B, C, D, E's of addiction for you. And so what we know is all diseases have kind of characteristic signs and symptoms. And that's what we use to determine what is the disease and how do we diagnose it. So there's actually a diagnostic and statistic manual for all psychiatric illnesses, and addiction falls into that. And so there's a list of 12 criteria that we use to diagnose a substance use disorder, including the severity of it. So you can have a substance-specific use disorder, like an opioid use disorder, and then we characterize it as mild, moderate, or severe. So we're going to talk a little bit about neurobiology. I'm not a very smart person, so I got to make it really simple. So we're not going to talk in like real high-tech words. So we got this area of the brain here, and we call that the brainstem. And that's, a lot of people call it the primitive area of the brain or the reptilian brain. So we've got this area of the brain right here, and what this area of the brain does is it's part of kind of the primitive areas of the brain, and it's very subconscious. So we don't really think about what's happening here. And what this area of the brain does is it sends this chemical called dopamine out. And dopamine is like the gas tank. So the gas is provided by this area of the brain, and it sends messages to the other areas of the brain, and this is called the ventral tegmental area, for those of you that like big, scary words. So the gas tank releases dopamine, and what does dopamine do? Dopamine is what makes things feel good. So dopamine is what makes it that, you know, I don't always have room for those last few carrots on my plate, but I always have room for dessert, right? Like, there's no question with my 5-year-old that he will always be able to eat ice cream. But he's so full from his dinner, right? And that's because when we eat ice cream, it actually releases dopamine, which makes us feel good. And that's why there's something special and different about dinner made by mom and dad than dinner made at a restaurant. The same food can taste different based on how our emotions interpret what that means. And that's because of this fun dopamine chemical. This is also the thing that makes things like sex pleasurable. We're going to go there. So if we really think about what we're doing in the course of having intercourse, if you just think about it from like a physical standpoint, it's kind of gross. It is, okay? Like, it's just kind of gross. Why do we do it over and over again? And why is there like $1 billion of money spent on preventing pregnancy? Because it's kind of gross, and the only thing that should come from it is pregnancy. So if you don't want to be pregnant, why are we doing it? Dopamine. Because it feels good. So we don't think about that. We just think about the fact that it feels good, and we do it again. And this area sends a message up here, and this area is part of what we call the cerebral cortex. That's the part of the thinking, the more thinking part of the brain, the more conscious efforts go there. And so I call this the go center. This is the area of the brain that gets the message of the dopamine. The dopamine is good, and it says, you know what? Dopamine felt good. We should do whatever that was again. And so it sends a message. Ooh. No, I messed. No, oh no. We're good. So it sends a message. So it sends a message up to the front of the brain, and it says, we are going to do that again. So we're going to do a little experiment. It's kind of right after dinner, so this might not work so good. Doesn't it look fantastic? Aren't you just aching? Don't you wish that out on that table they had a whole big bowl of carrots? Yeah, just ready to munch on. Feel different now? Probably some more people wish there was one of these out there. Anybody in the room lactose intolerant? Okay. What did that make you think? Whoa. No, thank you, right? You'll go for the carrot over that, right? Because you have like this thing that makes you have a different reaction to this. This doesn't make your brain release dopamine. It makes your brain release the like stop chemical. It makes your brain say like, let's not go there, right? Is that how you kind of feel right now? Okay, I get in a nodding head. I take that as a good sign. So I'm onto something, right? So different people react differently to different stimulus. So I tell people, I'm sure my husband loves that thousands of people know this about him in Grand Rapids alone. So after we had our daughter, 10 days postpartum, my husband went to see the urologist and had a vasectomy. We were done. And he came home from said vasectomy, and the doctor had given him 10 tablets of Norco. So we've got a 10-day-old baby. Whatever, go lay on the couch. I don't even know what's going on. I'm so sleep deprived at this point. And so my husband comes to me and he's like, I don't feel very good. Apparently, I don't know, maybe some of the men in the audience can help me, but apparently throwing up after you have a vasectomy is not a pleasurable experience. I don't know. So my husband, needless to say, gets nauseous when he consumes opioids. So he's protected from an opioid use disorder, right? Because his brain does what the lactose intolerant brains do when they see this. It says, oh, don't even think about that because that is going to make me feel crappy. There's more serotonin, the happy chemical, from the brain in your gut than there is in your brain. There's more opiate receptors in your gut than there are in the brain. So we know that they have this connection and that the body likes to reuse the same thing over and over again. It's not very smart, or maybe it is really smart, but it does reuse the same thing. So those people that saw this, when you first saw it, and you're not lactose intolerant, something happened. You probably had a little bit more saliva go into your mouth. If you haven't eaten dinner, it's now 7:15, you probably start to feel a little bit hungry. The more I've left this up, the hungrier you've gotten. You might not have been hungry before you saw this. Why is that? Because your brain is reacting unconsciously. You're not thinking about it. You're not saying, gee, this isn't real. This isn't a giant ice cream. So why are you producing saliva to eat my ice cream? It's a picture. Because your brain isn't that smart. Your brain just sees it and it says, yum, and it says, if I'm going to eat that, I need to produce saliva, and so your body produces saliva. This is what happens to my patients when they think about or when they see substances. So imagine how hard it would be if you had, say, an alcohol use disorder and you're driving down 131 and you saw the Beer City, USA sign. What's that going to do to you? And what do you have to do to prevent it from doing that to you? It's going to make you think about using. It's going to make you think about alcohol. You might not come all the way to the conscious part of your brain because just like you know that that's a picture, nobody is up here, nobody's fooled by my trick, right? I'm not a very good magician. My patients aren't fooled by the billboard, but they still react to it. And I'll bet you that at least a couple of you guys in the next couple of days are going to have ice cream. You can blame it on me. So it's our effective response to the images that cause our body to unconsciously respond to different stimuli. And we don't always have control over it. So then we went from here to here, and now we're going to the frontal cortex. And this is the CEO of the brain. This is the part that says, you know, as much as you want to, you cannot just have ice cream for dinner every day. Now, I know that. I'm sure most of you know that. But my 5-year-old, if I gave him the choice to have ice cream every day for dinner, he would have ice cream every day for dinner. Because he doesn't have a full frontal lobe. In fact, your frontal lobe isn't actually fully developed until at least your mid-20s. They say 25 to 28. So some of you all don't have a fully functional frontal lobe. I'm just saying. And the frontal lobe is the CEO, and that's the conscious decision-making part of our brain. That's the part of the brain that we use when we're thinking. That's the part of the brain that we use when we're making decisions between good and bad. That's the part of the brain that says, okay, you have to have something good for you before you have the ice cream sundae. And you can't have 8 scoops of ice cream, right? That's the part of the brain that helps us put that stop, puts that brake on these unconscious area of the brain and says, you know, maybe that's not a great decision. Now, that area of the brain is a little bit malleable, right? And so the more we get these dopamine releases, the more this area of the brain says that was a good thing, we should do more of it. And the more it sends that message to the front that says, ooh, we should do that again. That felt really good. I liked that. The more this area of the brain, the harder it is to say, no, that wasn't a good thing to do. And so it can become harder and harder to make the right decision if your brain's getting overwhelmed by these unconscious parts, right? And so this is where addiction lies. And so in order to change that messaging, this area of the brain has to kind of grow stronger and learn some new tools. And so it's not just about one thing or one decision. It's about a series of things that have happened to somebody. And, you know, this guy isn't fully developed until you're at least 25. And just for the record, the average age of first use of an illicit substance is 12 years old. I don't know about anybody else in the room, but I wasn't very far from playing with baby dolls personally when I was 12 years old. And I certainly wasn't thinking about the consequences of my actions now that I'm in my 30s, right? I'm going to bet, even though you guys, a lot of you are a lot younger than me, you weren't thinking about today when you were 12 years old, right? Because we weren't. We literally didn't have the frontal lobe to do it. We couldn't, right? We don't have that impulse control until we get a little older. Now you can kind of think through the consequences of your actions. If you don't study for that exam on Tuesday, what's going to happen, right? And that can sometimes be the reason that you study for that exam. Because now you guys have the capacity to think through some of that. When you were 12, it was harder to do that because your brain just didn't work like that. So this dopamine thing is just fascinating. It's just amazing. So we usually circumcise, if we're going to circumcise a baby, we usually circumcise them in the first few days of life, right? And this is where you cut off the foreskin on the male penis. So, yes, I'm going to pick on the men again. I like to pick on men. So let me just think about this. Okay, so when we circumcise a baby boy, what we do is we take them into a procedure room and we numb up their penis and then we cut that skin off. And when we take them back to the mom, this is usually done while mom's still in the hospital, baby's less than, 2 days old, right? And we give the baby sugar water if they start crying. And they stop crying. Because their brains haven't seen high doses of sugar, right? Because for the vast majority of women who don't have diabetes during pregnancy or that's uncontrolled, their baby's only seen a slower controlled level of sugar. And so this is the first time their brain has seen that amount of sugar. So what does that area do? It's like, ooh, cool. I'm going to release some dopamine. I'm going to increase the normal rate of dopamine by 200%. And that's going to feel fantastic. Right? And that's part of survival because we want baby to eat because breast milk is very sugar laden. And so we want baby to get that. But then, now, I'm just guessing that if we were to do a circumcision on any one of the men in this room and I were to offer them some sugar water, how about a lollipop for pain control? They would probably not be very happy with me. May have some choice words for me, right? And that would kind of be appropriate. I'm going to give you guys that much. Because now your brains have all seen a lot of sugar and had those spikes. And as your brain sees that sugar, it starts to release less dopamine. It starts to not respond in the same way because it gets kind of what we call sensitized. It starts to say, sugar's just there. It's just something we have. And now our new set point for feeling really great when we have sugar is higher than it was when we were first born. And this also happens with illicit substances, substance of misuse. We know that we have identified over 1 billion with a B chemicals, right? So we know the chemical structure of over 1 billion chemicals. That's crazy. That's like substances, right? Only about 200 of them affect that area of the brain. So we only know about 200 different things that can do this with dopamine. Pretty amazing, right? And so we have the brain sensitized to sugar, and I can say, like, my children, the poor children, my poor kids. So we do piano, and my son practices piano for about 45 minutes a day. He's 5.5. I am a cruel mother. And at the end of his piano practicing, he gets a Skittle. And we talk about this Skittle the whole practice. Are you going to pick a purple Skittle? Are you going to pick a blue Skittle? Right now we have like tropical fruit Skittles that came in like a pink package. His favorite color is pink, so that was very exciting when we got to pick out the pink package of Skittles. So we talk about the Skittle for 45 minutes, and it is rewarding enough to that kid's brain, one Skittle, that he will practice piano for 45 minutes. Now, not that he doesn't like practicing piano. You know, we try to make it fun, right? But you try to get me to do something for 45 minutes and talk about a Skittle, and I'd be like, yeah, right. Where's the rest of the bag? So we see that the brain kind of changes its response as we get older. So this is a control brain, and this is that frontal lobe, that front area of the brain. And this is somebody who used cocaine. And this is an older study, so it talks about abuse. We do not use that word anymore. We use use disorder. So this is an individual with a cocaine use disorder, and this is a control study, control patient. And so if we look at these colors as we go up, it shows that the closer to red it is on the rainbow scale, the more sugar that's being consumed by the brain and the more work that the brain is doing. So you can see that there are actually physical changes in the brain resulting in less work being done with by the brain in somebody who uses compared to somebody who doesn't. Right? So their brain literally is disrupted. It's not functioning the way it should be. Just like in diabetes, the pancreas is not releasing insulin the way it should release insulin. So the brain is just not able to function. So I can't expect my patients to do the same things that I can expect somebody without a substance use disorder to do. What's really amazing is that over time, in the absence of cocaine, this brain will start to look more like this brain. And it's pretty remarkable. There's some studies that have been done where it actually looks at on the order of days, weeks, months, that the brain actually regains function. Pretty amazing stuff. Yeah, we can skip that one, skip that. Okay, addiction is a biologic disease resulting in characteristic signs and symptoms. And we know that we have identified some of the biology. We've defined the signs and symptoms so we can diagnose it, and that leads us to treatment. So what we're going to talk about a little bit is the epidemiology next. You'll see that this is one of my new slides, that this goes all the way through 2014, which is our most recent national data. And if we look at the dashed line as drug overdoses involving opioids, and we look at the solid line, and that's all drug overdose deaths. And gee, those look like they're quite similar. So the CDC has declared the opioid crisis an epidemic. Interestingly, this is the first and so far only man-made epidemic. Every other epidemic that has been declared has been an infectious disease vector of some sort. that has been officially declared by the CDC. Some people will call it an obesity epidemic, but that is not officially declared by the CDC. That's usually a question, so check that one off. So this is overdose by drug, again, national statistics, and you can see that fentanyl and fentanyl analogs is this one that has just gone out of control. Heroin is this one that kind of mimics that. Prescription opioids are this nicely, steadily increasing one here. And then this is cocaine, methamphetamine, and methadone. And what I'd like to point out about fentanyl and fentanyl analogs is that we cannot separate out prescription grade, pharmaceutical grade fentanyl from illicitly produced fentanyl. So those end up being lumped together, and a lot of this may be illicitly produced as well. And so what we know is that when we don't know what we're getting, we're more likely to overdose than when we do. However, we can see very clearly that we are prescribing more and more prescription opioids, and more people are overdosing and dying from their prescription opioids. This looks at us here in the Midwest in terms of death rates from natural and semi-synthetic opioids. So there were 2,302 deaths in 2015. And we are kind of maybe doing a little better than some of the other areas. And this is age adjusted. Lighter one is 2014, darker one's 2015. So we see the biggest increases in the South and in the Northeast. And this is the Kentucky that you're always hearing about in this type of thing. And this is Massachusetts. So this is now comparing the United States to Michigan. We are doing a nice job of outpacing the rest of the United States in terms of people dying. I'm not sure that's quite a good thing, right? So we're actually ranked number 18 for overdose deaths in the nation. This is a state of Michigan county map from the Office of Recovery Oriented Services, 2013 to 2015. It's not publicly available, so if anybody wants any of these next 3 slides, you'll have to just let me know. And the hash mark ones, the hash marked counties are ones where fewer than 7 people died, and by national law, we can't report those statistics because it would be too easy to kind of figure out who that individual was. So we can see kind of our area here, Kent County, Muskegon, Ionia, Ottawa. So this is kind of essentially our Allegan, our essential catchment area. And we are kind of in the middle, but are surrounded here in Kent County, but are kind of pretty well surrounded by areas that are suffering quite significantly. Some of the thought around why we might be different is multifold. Our community mental health, which is Network 180, has a ton of resources in Kent County. We're one of the most resource-rich counties in our state in terms of substance use treatment opportunities. We also have a group called Grand Rapids Red Project. Full disclosure, I'm past board president, and that is our local needle exchange, naloxone rescue kit provider in the community. And what we know from data from Massachusetts is that the more naloxone in the community, the lower the death rate. So we think that that may, in part, be related to those factors. So we have more access to treatment and more safety net areas. We have the ability to provide people with multimodal therapy, so we can better match the individual to the best treatment for them. So heroin use is increasing amongst almost all demographic groups, and the overdose deaths are climbing. There's been a 286% increase since from 2002 to 2013, so over 10 years. At the same time, we have seen an increase in heroin addiction, but it does not, that somewhat parallels that, but has not gone up as high as well as that, and that gap is likely due to prescription opioids. Heroin mortality rates, so we're doing pretty well with killing people compared to the previous slide. We also think that may be in part because we have more treatment opportunities, and so one thing that sometimes happens is that people go into an abstinence-based program, so they're not getting medication-assisted treatment, and when they leave that abstinence-based program, they're at higher risk of overdose death because their brain has kind of recalibrated a little bit, not completely, but a little bit, to not needing as much opioid, to not being as tolerant to as much opioid, so the same amount of opioid can lead to death. There's also hypotheses that our dealers in our county are just giving more potent drug, and so people don't realize what they're taking. So this is total drug poisoning mortality rates, and then this one is heroin specific. So you can see that those kind of parallel each other. So this is an interesting slide. It's kind of busy, so I'm just going to cut to the chase. So this is death, medical examiner death from the state of Michigan. It's a little bit older, 2009 to 2012. This is the most recent data. And the important thing right here is this 59%. We're just going to focus on that. And what that bar is saying, so this is the red is total drug poisonings. The blue is drug poisoning deaths who filled a prescription within 364 days of their death. And the green is people who filled a prescription within 30 days of their death. So this 59% means that of these 669 people who died of an overdose, that on their medical examiner data for the state of Michigan, it attributed their death to an overdose, to complications of an opioid overdose. 59% of those people filled a prescription within 30 days of their death for the drug that killed them. So 59% of people who filled a prescription for the drug that killed them in a Michigan pharmacy, written by a Michigan prescription, written by a Michigan prescriber within 30 days of their death. That's just scary. So it's not just those illicit opioids, it's also the prescription ones. And this is likely very much underreported because we do not do chemical analysis on every death, right? So if somebody has maybe COPD, chronic obstructive pulmonary disease, and has breathing issues, their respiratory drive in the brain, instead of being set by the amount of oxygen, switches over to being set by the amount of carbon dioxide in their brain, and that causes them to not be as responsive to the amount of oxygen in their body. And so when we give people opioids, again, opioids in the gut, opioids in the brain, it's in multiple areas of the brain. It actually hits that respiratory center, that breathing center, and it slows it down. So these people die of they actually die of an overdose, but because they have end-stage COPD, no autopsy is done because they just assume that the patient died of their COPD. So we're actually vastly underreporting this. Michigan mortality by age. This would be, for Michigan prescription drug-related mortality by age, this would be the 35 to 54-year-olds. This would be the 21 to 34-year-olds. So we are losing our most productive and active members of society to this epidemic. No? You gave a funny look. Oh, you're not in that age group. Yeah, you are. But a lot of the people that are 50, there's a significant portion of the 55 plus age group that's retired. Not you, Dr. Weston. You're not allowed to until I'm no longer my SAM president. And then 16 to 20 tend to not be working as much as that 21 to 54 age group. So if we look at so this is talking about a treatment gap. So what we see in our fine state of Michigan, it's so convenient being in Michigan, it's easy to like pick out like which one of these is North Yeah, how many of you guys were actually able to find North Dakota when I said that? I'm just saying. So Michigan, if we look at Michigan, we're actually in the second highest rate of dependence for, so having a substance use disorder of the different scales, right? So we're in the second highest rate of having a substance use disorder. But see this little tiny little dot here? That's our treatment capacity. So we've got a lot of people, but not a lot of treatment. That's not good. That's a disconnect, right? We need more people treating so that we can address the community that we have. So there's a lot of access barriers. We're going to talk a little bit about barriers to treatment next. So there's a lot of access barriers. There's not enough providers. There's limited numbers of providers. There's limitations on the numbers of individuals we can treat. There's limitations on the number of individuals a social worker can treat. There's limitation on the number of individuals a physician can treat. So there's all these limitations which result in waiting lists. One of our Spectrum Health clinics is closed to new patients because they're at capacity for social workers. They have capacity. They could treat more people. They feel like they could, but that number makes it so that they can't. And this is not unique to that clinic. This is something that happens in all different care settings, in methadone clinics, and buprenorphine clinics, kind of in all the substance use treatment licensed programs. There's coverage limitations by insurers. There's utilization management processes. So there's these people that sit somewhere that aren't seeing the patients that are saying, you know, I don't know about that, Dr. Poland. That Suboxone stuff, which is the trade name for buprenorphine naloxone, costs us about $700 a month to pay for. I don't know if that's a good choice for this person. It's kind of expensive. We've got some program personnel barriers. We've got a lot of people still in treatment that are providing treatment that don't believe that medication has a place to treat, when what we know in the evidence very clearly shows that medications improve outcomes overall. In fact, just the fact that somebody comes in and sees a doctor improves their outcome over somebody who doesn't come in and see a doctor, somebody who comes in and sees a social worker or a different provider. And that's, just the placebo doctor effect. There's still this belief that medications substitute one substance for another. This was founded in a lot of the AA and NA literature. There's belief that alternatives are better than medications, and there's a significant number of people that do not support medication-assisted treatment. Medical staff barriers. A lot of treatment programs lack access to qualified healthcare providers who can prescribe or who have the capacity to prescribe. So with buprenorphine products, we're limited as providers in terms of the number of individuals we can have on that medication. It is the only medication that has any sort of random arbitrary limit. Technically, if I wanted to prescribe some crazy chemotherapy medication, I could do it. I just would have no idea how to give it to somebody. So it's probably not a very safe thing to do. But nobody puts a limit on whether or not I can technically write a prescription for any other medication other than this buprenorphine, write a prescription. No, and with methadone, it's also slightly different in that you cannot write a prescription for methadone for the treatment of addiction. So that's why we have methadone clinics where they dispense methadone. So the patient never leaves the methadone clinic with a prescription. They never go to the pharmacy for that medication. They go to the methadone clinic and they get dosed daily at the methadone clinic. And then as they progress and are doing well, they get what they call take-homes, and they get doses that they take home with them. But those are all given to them and dispensed at the methadone clinic. There's funding barriers. A lot of states will not reimburse for physician services. Funders won't pay for the laboratory tests. They won't pay for the medication. The patients can't afford the medication. There's regulatory barriers. I touched on that a little bit. So there's all sorts of kind of rules and regulations around what can and can't be done. These vary state by state. So just because I can do it here doesn't mean I can do it in Ohio. Just because they can do it in Indiana doesn't mean that I can do it here. So it's hard to necessarily find that. We sometimes find that to be difficult in the Upper Peninsula specifically because we have some border regions that will not fill prescriptions from outside of the state for medication-assisted treatment. The pharmacies are just refusing. And a pharmacist can refuse. It is within their scope of practice to refuse to fill a medication. So we experience that right here in Michigan. So how do we treat it? We have 3 FDA-approved medications. I always tell people I am just not the smartest person, so don't make things too complicated for me. I can handle 3 medications. If we throw alcohol in there, that makes it up to 5, and then we can get really back down because 5 is just way too many. I am not in a methadone treatment program, so I cannot utilize methadone for the treatment of addiction without violating the Harrison Act of 1914. I try not to break laws. And then disulfiram or antabuse for alcohol use disorder is just kind of a cruddy drug that doesn't work very well. So now we're down to 3. So anyone can be an addiction doctor is what that means. And studies, again, show that medications are effective in treatment. So we've got 3 FDA-approved medications. They all have different ways that they act. Only 30% of treatment programs nationally currently offer medication, and that results in less than half of eligible patients receiving medications. And what all of these medications essentially try to do is stabilize those brain structures so that the patient can focus on the thought processes, focus on that CEO of the brain, try to develop that frontal lobe a little bit more. I'm going to skip over a lot of this. Okay, so those receiving medications as part of their treatment are 75% less likely to die because of addiction than those not receiving medication. It is cost effective. We save money. For every $1 invested in addiction, we save $4 to $7 in drug-related criminal activity, and we save up to 12, when we include healthcare cost savings exceed a 12-to-1 ratio. So every $1 we spend treating addiction, our community saves $12 overall. So addiction and isolation. So there's this fantastic 1970s and 80s experiment was published in 1981 by a guy named Bruce Alexander out of Vancouver, which continues to be, to this day, one of the most forward-thinking addiction treatment areas in the world. So what he noted, and this is where kind of the war on drug stuff started. Anybody involved in DARE programs and school might remember that kind of just say no mentality we had back in the olden days. A lot of you are probably not even remembering that because I'm old. So in the 1970s and 80s, they did these experiments where they put a rat in a cage and they gave the rat the choice between cocaine and water, and the rats used cocaine until they overdosed and died. And so we said, well, exposure to cocaine will automatically lead you to using cocaine to the exclusion of anything else until you die. Makes sense. Then this guy came around and he said, well, you know, you're isolating those rats. And we know that rats are kind of social creatures. They like to be around other people, animals, things. So he built Rat Park. It had toys, food, tunnels, friends. It was rat paradise. It was wonderful. And what he found was that rats alone, he put some rats in their little cages in isolation, and they drank the drugged water. And the rats in the park kind of tried the drugged water, but they didn't really continue to use it. And if you Google search Rat Park cartoon, these are blatantly stolen. And you can kind of go through the whole experiment if you're interested. So the rats in the park tried the drug water, but the vast majority of them didn't continue to use it. Why were they different than those rats alone and drinking the drugged water? So what he said was there must be something about that social atmosphere that makes those rats immune to addiction. Must be something about maybe not being exposed to excessive carbohydrates that makes people have less type 2 diabetes, right? So it's an exposure thing maybe. So we had this thing called the Vietnam War. And in the Vietnam War, about 20% of soldiers used heroin while on duty. So there was this huge concern that we were going to have all these heroin-using people coming back after the war, and we were going to have this huge addiction epidemic, and it was going to be terrible and awful, and all these people were going to die, and heroin was going to like be the scourge of the universe. Didn't happen until many years later, but at the time, we thought that's what was going to happen with these soldiers that came back. And what we found was that that a lot of them reintegrated back into the community and stopped using heroin with no treatment, because home was Rat Park compared to the Vietnam War. That was like isolation in a cage. It sucked. Right? So 95% of the soldiers just continued after returning home. Now, that rate of use is still higher than the general population. And, so meanwhile, back in Rat Park and Bruce Alexander's lab, so he took some of these rats and he put them alone in the cage for 57 days, then put them back in Rat Park, and they went through withdrawal, but they didn't use as much. Now, their overall rate still stayed above the rats that, were always in Rat Park, but it was still less than the isolated rats. So people who are prescribed short-term monitored amounts of opioids for injuries do not necessarily become addicted to heroin. It is not just the exposure that automatically results in a substance use disorder. So are there social markers that increase risk, and what makes a person feel isolated? So we have a culture, one postulated theory is that we have a culture that's more connected than ever electronically. There's Facebook and Snapchat and all that kind of stuff, right? Like we've got all these things that we use to communicate with each other, and that has been at the expense of developing human relations. I call them 3D encounters. You cannot see 3D through the computer screen. It is a 2D media, right? You do not get a feel of depth. You do not get that tactile expression. We are, like rats, social creatures. So is the rise of addiction a symptom of the information age? Humans have a need to bond and form connections. What we know, what studies show, is that in a neighborhood in the 1950s, 60s, and 70s, on average, people got together with their neighbors 10 times a calendar year. Today, it is 2. So for too long, we've talked exclusively about individual recovery from addiction. We need now to talk about social recovery, how we all recover together from the sickness of isolation that's sinking us like a thick fog. That is from the gentleman who did the Rat Park experiments. And so one of the things that I think will hopefully help us solve this crisis is to increase the community mindedness, increase the opportunities for our young people, our kiddos, our kids in elementary, middle school to have safer communities where there's more interconnectedness on a very personal level. Michigan State University is a community-based campus. We are all over the state, and part of these lectures is to encourage the beginning of these conversations to hopefully build safer communities and looking at the resources that we have to be able to do that. I end all of my lectures to all the people who have lost their lives to addiction and those that try to prevent further losses. I lost my younger brother to the disease of addiction. He had an alcohol use disorder and committed suicide about 5 years ago. It'll be 5 years on December 23rd. And so this is also very near and dear to my heart. And so thank you for joining me tonight and hopefully joining me in the fight against addiction. Thank you.
We have time for a question and answer session. So if people would like to ask Dr. Poland any questions, I could bring the microphone around. Mm-hmm.
Okay, so I told my mom that I was going to an event tonight, and then she told me something, I don't know how long ago she saw it. It was basically about when mothers, when they're using opioids, when they're pregnant, and like they give birth to the child is addicted. Is it true that there's like hospital cuddlers? Like she talked about it where they cuddle cuddle the baby when it's born, and like that helps the most because the baby's close and is building a bond?
So babies are not addicted. I'm just going to start there. So babies can be physiologically dependent, but the diagnosis of addiction requires you to have some behaviors and processes, and babies just can't do that. They don't have the brain capacity to do that. So we do have babies that are born physiologically dependent on opioids, and if that happens because they will not have opioid from mom coming into them after they're born, they will have what we call neonatal abstinence syndrome, which is baby withdrawal. And what we try to do first is we try to, just like anything else, if your blood pressure is starting to rise, but we'll tell you to, make some lifestyle changes, maybe, cut out some of the salt, do some exercising, things like that. In the same way, when a baby's going through withdrawal, we have a kind of a scoring system. It's called the Finnegan scoring system. And we will look at what the baby's doing, and we'll start with non-pharmacologic, non-medication ways to manage that withdrawal, decreasing the amount of stimulus, keeping the room kind of the lights dim, the sound low, making it nice and calm so that we can all be in Zen period, keeping them kind of wrapped up, putting them into a kangaroo bouncer if we can't, but certainly cuddling them, and that physical connection is very important. There is an imprinting process in humans, just like in other animals, and a lot of that is about kind of having that skin-to-skin contact. So when babies are born, they can only see about 20 centimeters, which is about, in a normal-sized adult, which I'm not, the distance between the baby's head and the mom's face. So babies can't make out colors very well, so they see, they can see the eyebrows and the hairline and things like that, and so that helps develop that sense of connectedness and calm the babies. If we do need to give babies medication to treat their withdrawal, we will give them medication. We're not in the business of making uncomfortable babies.
Thank you.
No problem. Larry, you're loud, just yell.
Any other questions?
Yeah. He's loud.
Okay.
Yeah.
Okay.
A year, 2 years ago, the opioid task force here in Michigan.
Yes.
Yeah. Is there actually anything moving on that? And also knowing that, the average person is trying to get a drug around the age of 12, is there any movement actually in Michigan schools?
So there's movement at the state level. Some of it is related to the Michigan prescription opioid and opioid abuse committee. Unfortunately, that committee does not have an addiction specialist on it. That is a gap. Apparently, it would take an act of legislature to change that. So everyone go home and write your county legislature and ask for them to have that changed. So they have been advocating for some changes. There was a 13-bill package that came out from the Lieutenant Governor's office. Lieutenant Governor Kelly is a strong proponent of equal opportunity for all individuals, regardless of mental health concerns, and that goes for everything from developmental delay to addiction to other behavioral health issues. So he's put forth that, and that's working its way through the legislature, and currently the one that's being debated is on requiring physicians to access a prescription database that lets us know a little bit more information about scheduled medications. And then there's also the House of Representatives has the CARES committee, and that is led by the Speaker of the House. They're a representative from both Grand Rapids and one from Allegan County are both members of that committee, and so they and they're actively working on writing some legislature around some of this substance use stuff. Of those 13 bills that the Lieutenant Governor's office put out that are active in legislature right now, 2 of them are around education within primary schools.
Any other questions?
I do a lot of advocacy stuff. Yes.
You can pass that down to her.
Okay. Hello. Just as a grassroots nonprofit organization here in West Michigan, what could we do for our local community? What model could we follow, or what services could we offer to promote health and wellness centered around this issue?
Can I ask what organization you're with, or are you just saying in general?
Yeah, I would prefer to just leave it in that
Okay.
family of nonprofit, grassroots, community outreach.
So, I mean, depending on what area that is, there's the opportunity to provide education for the population that you're serving. There's the opportunity to provide access to care by partnering with the various treatment programs in the area. Often that's done through Network 180 certainly for the Medicaid and the underserved and the otherwise underserved population, uninsured and uninsured population. There's opportunities to help provide some of these community messaging out. We do have another kind of grassroots organization that's been growing in Grand Rapids called FAN, which stands for Families Against Narcotics. It's a Michigan organization. Their meetings are the first Tuesday of the month, I believe. Is that right? Yeah, the first Tuesday of the month at St. James Church. And so and you can search them on the internet to make sure that I'm 100% accurate in that. But they're the first Tuesday night, and they kind of promote coalitions and working together. There's the Kent County Health Department in partnership with Grand Rapids Red Project, who received a grant from Steelcase Foundation here locally, has an opioid task force and specifically around overdose. That's another way to get involved, really making connections. Grand Rapids Pride is a big partner for Grand Rapids Red Project and kind of partnering with others. So is Grahi. There's lots of, kind of seemingly unrelated partnerships that happen. And the more that those partnerships happen and the more people hear the same messaging coming from various organizations and various groups, the better we're able to get that, to turn that message from necessarily being grassroots to being kind of a mainstream message. And it's a bit of an uphill battle. There's still a ton of stigma around addiction. If you notice, where did I spend most of my time? Talking about the brain, pointing out that this is a disease of the brain. This is a malfunctioning brain that we can fix, that we can change to help these individuals lead the life. What we talk about in our clinic is that we want to help these individuals lead the life that they want to lead. That might not be the life that I think they should lead. And that's a pretty distinction, right? So we want to help people live the life that they want to lead. And I can't help people live the life that they want to lead without the help of all of the nonprofit organizations. We partner with the food bank, Feeding America of West Michigan, and we have a food bank, and full disclosure, my husband and I fund it, but we're able to provide our patients with food because a lot of these folks have unstable living situations. So I, as a parent, will definitely say that if I'm standing there and I've got $3 to my name because I'm on a fixed income from Social Security of $750 because I am disabled due to my mental health conditions or physical conditions, and I have $3 to my name, am I going to pick up my $1 copay prescription, or am I going to pick up a box of spaghetti to feed my child? I'm going to pick up that box of spaghetti. So that's why I've chosen to partner with Feeding America in order to be able to provide food to my patients so they don't have to make that decision. And we need to be looking at all of those things that people need in order to be able to focus on their health care. Because without that support, without knowing where you're going to sleep every night, without knowing that you're not going to be hungry, 1 in 6 children in Kent County is hungry every day. That breaks my heart every day. And until we solve that, we can't solve other problems. Because if your brain is developed without fuel, what do you think happens as they get older? So it's not just about treating substance use, it's about building a healthier, safer community. The Rat Park of Grand Rapids. Yes, young man.
I've seen several studies. I think I'm good. I got a loud voice. All right. I've seen several studies that show a direct correlation in states that have legalized medical marijuana and legalized recreational marijuana and decreased rates of opioid overdoses. So from your perspective, do you see medical marijuana as a reliable treatment method for opioid use disorder?
We can talk more about that. That's a pretty long question. Suffice it to say, those studies are pretty poorly done. There is no such thing as medical marijuana. So there's this body in the United States called the FDA, and what they do is they approve medications and they kind of keep us safe. They're the ones that regulate, like if there's a salmonella outbreak, they're the ones that track it down and figure out what jar of peanut butter it started with, so to speak. Not to pick on peanut butter, but they're the ones that kind of do that stuff as well. And so when a new medication comes out, when I prescribe somebody a medication, doesn't matter what it is, I prescribe them a dose, a route, a frequency, and a quantity, right? When somebody writes for medical marijuana, they're prescribing a gram of plant. Now, let's talk about aspirin. Everybody's heard of aspirin, I'm going to start with, correct? Okay, so, and if you go to your doctor, your doctor might suggest, especially maybe if you're a wiser person in our audience, that you take a baby aspirin for cardioprotection, right? And they prescribe 81 milligrams. 81 milligram baby aspirin. They don't tell you to go find a local willow tree, cut a 1 inch by 2 inch rectangle out of the willow tree, weigh it so that it is 2 grams, dry it, I don't know what other processes, maybe spray some pesticide on it, and then chew on that. But you know where aspirin comes from? It comes from the bark of a willow tree. So when somebody is written a prescription for marijuana, we have no idea how much active ingredient we're giving them. As the years have gone by, we've seen an increase in the amount of the chemicals in the marijuana. We've seen an increase in the active ingredients. We've also seen a parallel increase in kind of the 2 major active ingredients, one of which results in increased risk of psychosis with intoxication from marijuana and especially vulnerable populations. Are you young men in your early 20s in this room? I know I'm just picking on the guys all night tonight. But that it can precipitate schizophrenia in somebody who has vulnerable genetics for schizophrenia. So there are a lot of risks. And we do actually have pharmaceutical grade marijuana. It's called Marinol. So we actually have that available. It just doesn't get people high. So those studies were actually pretty poorly done. And we can talk about the specifics of that if you're interested later. But that's kind of so that's one end. That's part of my spiel on marijuana. So I call it voter-approved marijuana because that's what it is. And then the other end is, so we've got 2 different questions. Are there medicinal properties of marijuana, which we know the answer to? We have purified it, we have tested it, and we have Marinol, pharmaceutical grade marijuana. And then we have the question of, do we legalize marijuana in the same way that we have legalized tobacco and alcohol? And at what age, in what routes, in what regulations, blah, 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 blah. And I feel that those are 2 separate questions that have, in the common world, been muddied into one, and I think they need to be separated out. Is that fair? No problem. I went over. You guys indulged me. I can stick around for a few more minutes. I have cards if people want them too.
Thank you.